So let's get started. We'll start with the fallopian tube maybe first. Very easy, it won't take that much time. So, all right. So everybody can see my screen.
Yes, we can.
Yes.
Okay. So I will start with the adnexal tumors or adnexal lesions, which include some fallopian tube stuff. So going over the key things that you need to know is very important. Like there, he's talking about some kind of adrenocortical remnants that you might see some remnants of adrenal gland in the adnexal area. Oh no, absolutely not. The first entity that I need you to know for sure, or make sure that you know it, is a paratubal cyst. And this is also not for the boards, but for our daily practice, because you might get some TAH and BSO, bilateral salpingo-oophorectomy, and you might see a little cyst which is nearby one of the fallopian tubes, and you take a section and submit it, and then you will see this paratubal cyst. So it's fairly common. It's a common cyst, very benign cyst. The size should be less than 1 centimeter. And it's lined by ciliated columnar or cuboidal epithelium with cilia. Cyst lumen is clear, and there is no stroma. There's no dense stroma in the wall. You just see a simple lining of ciliated columnar to cuboidal epithelium, and that's it. No signs of malignancy, no malignant changes, no invasion, nothing. Just letting you know that if the size of the paratubal cyst exceeds 1 centimeter, you might call it serous cystadenoma. However, it rarely does. It's usually less than 1 centimeter, very small paratubal cyst. You say benign paratubal cyst, and that's it. It's usually written in the diagnosis and nothing else. There is also this salpingitis ethmica nodosa, tubo-ovarian abscess. It's a no. You need to know Wolffian tumor. Well, okay, Wolffian tumor, when you sign it out, you usually call it female adnexal tumor of probable Wolffian origin. This tumor arises from remnants of Wolffian duct. Wolffian duct should differentiate into the male genitalia, or kind of male sex organs, internal genitalia. This is the Wolffian duct. So some of the remnants of this Wolffian duct might end up having some Wolffian tumor or a Wolffian tumor, which might arise in the fallopian tube or in the adnexa. All what you see here is just these tubules or tubular structures. See, you see tubules which look like glands. The tubules have eosinophilic or hyaline material inside. Glassy pink hyaline eosinophilic material inside. That's it. However, this can mimic a lot of stuff. You need to do some immunos to confirm. I said that the Wolffian is an origin of male. It's a male duct or a male tube, the Wolffian duct. So you stain for androgen receptor. So please remember that this is androgen receptor positive, because it's kind of a male lineage, so it makes sense with androgen receptor. It makes sense. It's also CK positive vimentin. However, CK and vimentin might be positive in a lot of stuff. However, if you see tubules with with gland-like tubules with these pink hyaline or hyalinized bands or eosinophilic secretions inside, and then it's telling you that this tumor is AR positive, so that's Wolffian tumor or female adnexal tumor of probable Wolffian origin. It's usually in the adnexa, distinct from the ovaries, some kind of somewhere in the broad ligament. It's not from the tube either, but it's just in there, in the adnexal structure inside the broad ligament. It has a lot of variable patterns. However, this is the most common pattern that you might get a picture for, which is the tubules and the eosinophilic secretions. Miscellaneous tumor, we always ignore that. Of course, you have to remember that we have high-grade serous carcinoma that you might have from the fallopian tube. Do you remember this? I hope you do. It's called STIC, which is serous tubal intraepithelial carcinoma. It's high-grade serous carcinoma of the fallopian tube. And do you remember, if we see high-grade serous carcinoma cells in the fallopian tube and there is high-grade serous carcinoma of the ovary, where would be the origin? What do you think? Which one would be the origin? Is it the tube or the ovary? Can anybody remember from?
Tube.
Tube, I think.
It's always the tube. The tube is always the origin. Even if the high-grade serous cells in the tube, they are not invasive. Even if you don't see invasion in the tubal stroma, sometimes it's there in the tube and then it makes its way to the ovary and make its way to the endometrium. It makes its way to both sides. So the high-grade serous carcinoma of the tube is a high-grade serous carcinoma or high-grade carcinoma with serous differentiation. It's called STIC. It's usually found in the tubes, and it makes its way to the ovary and to the endometrium on the other side. Since it's high-grade serous, please remember that it's P53 mutant and P16 positive, right? P16 positive, P53 mutant, and Ki67 is usually high, more than 10%, since it's a high-grade tumor. By the way, STIC is common in BRCA people. The people have BRCA mutation, BRCA gene mutation, which is also associated with high-grade serous carcinoma of the ovary. This is BRCA, and it's also associated with breast cancer, as we all know. Here is saying criteria for assigning primary site of extrauterine high-grade serous carcinoma. See, if tube is always the most common site, you need to memorize that, especially when you see STIC. When you see STIC, it's the tube, no debate, no doubt. However, it might be the ovary, might be tubo-ovarian, might be peritoneal, because there is a high-grade serous carcinoma of the peritoneum. But to call a high-grade serous carcinoma of the peritoneum, the ovaries and the tubes must be completely free. You must have submitted the entire tubes, the entire ovary, and you are 1000% sure that they are cancer-free or they are tumor-free, and even the uterus. So usually the most common site of high-grade serous is the fallopian tube, especially when you see STIC. That's it for the fallopian tube and the adnexal tumors. We want to now go over the mesenchymal tumors of the uterus. Let's get started. That's very important. The key thing for you is to know which tumors you definitely need to know before your board, and also for your general practice. Like when we're talking about mesenchymal tumors of the uterus, of course you will end up putting the bunch of mesenchymal tumors that you might see anywhere. Like for example, he will put in this notes, he have inflammatory myofibroblastic tumor. Well, it comes in the boards, but it never come in the uterus, honestly. You will put picoma. Picoma also come in the boards, but it doesn't come from the uterus. It usually comes as a soft tissue tumor. The same thing for inflammatory myofibroblastic and desmoid. They always come as abdominal masses or soft tissue masses in the abdomen. So you need to know what is common in the uterus as a mesenchymal tumor. Of course, leiomyoma. Okay, daily life. That's your daily life thing, bread and butter. That's leiomyoma and how to differentiate leiomyoma from leiomyosarcoma. This is highly, highly boardable, and you need to know it for sure. Let me ask a question first. Does anybody know what is the most important histopathological feature to differentiate leiomyoma from leiomyosarcoma?
Is it necrosis?
Coagulative necrosis, not any necrosis. Coagulative necrosis, but good, that's a good shot, because you might end up having a question. You might have a question. I got this in one of the Q banks. Yeah, the Q bank asks you, what's the most significant or the most important histopathological feature to differentiate leiomyoma from leiomyosarcoma? And then they ask you about atypia, they ask you about mitosis. They put atypia, they put mitosis, they put necrosis. Every criteria works, but you need to know the most significant one. The most significant, most important one is tumor type necrosis, not any necrosis. It's coagulative necrosis. I will show you this. And I will tell you what I mean by tumor type necrosis, rather than having some ischemic necrosis, which might happen in a leiomyoma, by the way. You might have some necrosis in the leiomyoma, but it's called ischemic necrosis, not tumor type necrosis. So leiomyoma is a benign, smooth muscle tumor. That's the most common uterine tumor that you will see. It's always there. It has many types. Subserous type, which is near the serosa, interstitial type, which is in the middle, and submucous type, which is towards the lumen or towards the endometrium. Of course, the subserous type are more likely to present with pressure symptoms because it's coming from the surface of the uterus, so it might press on the urinary bladder or press on the rectum. So this is more common to have pressure symptoms, press on the surrounding. And this most likely to have some menses-related symptoms like menorrhagia, dysmenorrhea, these kind of things. Interstitial is kind of in the middle, so it might do both. It's usually, the leiomyoma usually multiple because it's hormone related. It's related to estrogen. Why that's an estrogen-dependent tumor? What's the proof for that? Is that after menopause, when the estrogen go down, this tumor or these tumors regress. They regress in postmenopausal women because the estrogen went down. So this proved that these tumors are actually estrogen dependent. So it's multiple, well-circumscribed tumors with this classic bands of spindle cells with cigar-like nuclei making some fascicles with whorly appearance or whorly architecture. They have a MET12 mutation. This MET12 mutation, by the way, is there in some breast lesions. We will encounter this in some benign, also breast lesions. You see this MET12 mutation is the same there. There is a lot of variants for leiomyoma. However, they would never, ever get you a picture like this. What's this picture? This is called leiomyoma with bizarre nuclei or symplastic leiomyoma. This is a leiomyoma with some bizarre looking cells which look like a sarcoma. Oh my goodness. I would never, ever be able to differentiate this from leiomyosarcoma based on a picture in a board exam. So that's why they will never get you a picture like this and ask you whether this is leiomyoma or leiomyosarcoma. Oh, come on, that's very hard. But you need to know that there is a type of leiomyoma with bizarre looking nuclei and bizarre looking cells, which look like leiomyosarcoma. And that's why relying on the cell morphology and relying on how the cells look atypical is not the perfect way to differentiate leiomyoma from leiomyosarc, because you have a type of leiomyoma which shows some kind of atypical cells and it's still a leiomyoma. It's not a leiomyosarcoma. See also this type. There is another type that I want to outline, the cellular leiomyoma. See, that's a subtype also of leiomyoma in which there is very, very dense cellularity. It's extremely hypercellular. So you can't rely on the hypercellularity as a criteria to differentiate leiomyoma from leiomyosarc, because you have cellular leiomyoma with a very abundant cellularity. See also this type, mitotically active leiomyoma. It has a lot of mitosis. That's why we cannot rely on the number of mitoses or how much mitosis is there to differentiate between leiomyoma and leiomyosarc. So that's the significance of knowing these types. However, when you get a leiomyoma in your board exam or in any of the board Q banks, they get the classic one, the one with classic spindle, cigar-shaped nuclei, and some kind of epithelioid-looking areas, which are actually tangentially cut cells, I believe. And they ask you maybe about the immunos, which is smooth muscle immunos. The smooth muscle immunos, the two most important one is desmin and SMA. Desmin positive and smooth muscle actin positive. There is also HCAL-desmon and ERPR. ER here is specifically positive because this is an estrogen-dependent tumor. Okay? So, but knowing the variance is important for you, because so that you know that we don't rely on cellularity to differentiate. We don't rely on how bizarre the cells look like. We don't rely on mitosis. We don't rely on having any myxoid degeneration areas or even epithelioid looking cells, because all of these are there in benign leiomyoma. You have these in benign leiomyoma. This is not pathognomonic for leiomyosarc. Okay? Okay. I've never heard about this metastasizing leiomyoma. Honestly, I just read it here. I even asked an attending about it. I asked him, is there a kind of metastasizing leiomyoma? He said, no, leiomyoma is benign tumor. It never metastasized. I told him, but there is a subtype that I read about, is metastasizing leiomyoma, which is benign appearing, but it's extrauterine. It's like there in the lung in a patient with extensive leiomyomas in the uterus. So they believe it might be coming from there. He said, no, I never heard about it. So I don't know. If we talk about leiomyoma, please remember this syndrome, which is hereditary leiomyomatosis renal cell carcinoma syndrome. Does anybody remember which type of renal cell carcinoma is there in this type of syndrome? The HLRCC? Which type?
I think it's written there.
It's written there. Yeah, sure, absolutely. It's FH deficient RCC. Yeah, it's FH deficient RCC, which is fumarate hydratase deficient RCC, but you need to memorize it even if it's not written here. So please memorize that when you have a patient with multiple leiomyomatosis, you need to specifically look at the radiology of this patient and see if there is any associated renal mass, which might be FH deficient RCC, and it's a kind of a syndrome which is HLRCC, hereditary leiomyomatosis renal cell carcinoma syndrome. So remember that for the leiomyoma. Okay, so leiomyoma, benign smooth muscle tumor with smooth muscle markers, desmin, SMA, CAL-desmon, ER, multiple well-circumscribed MET2 mutation, some kind of subtypes that we try to outline the most important ones, but you need to remember the HLRCC, FH deficient RCC. Leiomyosarc, here it is. See, yeah, I agree. The cells look bizarre. See that? The cells look bizarre, pleomorphic. You see a lot of mitosis here, right there. Well, a lot of mitosis, and right here, here is another one. So bizarre looking cells, high grade looking cells, pleomorphism, high NC ratio, prominent nucleoli, blah, 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 high mitosis in a tumor which have a smooth muscle differentiation, smooth muscle lineage. So it's still Desmond positive, SMA positive, and H. caldismon positive. However, you have these diagnostic criteria, which include marked cytological atypia, 2+ or 3+ atypia, increased mitosis greater than or equal 10 mitosis per 10 high power field, and the most important criteria, which is the tumor type necrosis. Tumor type necrosis means coagulative tumor cell necrosis. What's the meaning of coagulative tumor cell necrosis? Anybody know? And what's the difference between coagulative tumor cell type necrosis and the ischemic necrosis? In the ischemic necrosis, you will see a red desert, red structureless desert-like area. But in coagulative tumor type necrosis, tumor cell necrosis, in coagulative necrosis, remember that the cell retains its architecture. It's like a cell ghost. See? Thumbs up if you see this. See this area? See this area, how the cells are still there, but they are very, very light. You can't really, but you can still see that there was a cell there. That's what the meaning of ghost cells or coagulative type tumor necrosis. And you always see this abrupt transition between the viable area of the tumor and the necrotic area of the tumor. So that's the meaning of tumor type necrosis, which is coagulative tumor cell necrosis with sharp interface between the viable tumor around and the non-viable tumor with the noticeable tumor cell ghosts. That's the most important criteria for that. Well, it's saying that there is some other subtypes of leiomyosarc, like there is epithelioid type. Epithelioid type, you see epithelioid cells, but still you see the cytological atypia, you still see the increased mitosis, you still see the tumor type necrosis. There is also a myxoid type, in which you see some kind of myxoid background. Here it is, loose myxoid background. However, still you see the cytological atypia, still you see the mitosis, and still you see the tumor type necrosis and infiltrative borders. See, what's common between all of them is the tumor type necrosis. So please remember that this is the most important histopathological criteria to upgrade a leiomyoma to a leiomyosarc. Okay? A question. If you have a uterus with a solitary large tumor in the wall and another uterus with multiple tumors here and there in the wall, which one would be most likely to be leiomyoma? The single or the multiple one?
Multiple.
Multiple. Yeah, that's correct. That's correct. The multiple, although it's multiple, but it's a reassuring sign. If you see multiple lesions in the wall of the uterus and they look like this, like whorly cut surface and bulging white uniform cut surface, that's highly likely to be leiomyoma. However, if you see a single huge one, I start to get concerned. Then I have to serially section this tumor very well and look at all the sections and submit representatives 1 per centimeter from the which areas you need to focus on and submit representatives from. If you have like a huge tumor,
The edges.
the edges, okay, for infiltration, right?
Yep.
And what else you will submit from the tumor? Areas of what? Yes, Mariam?
You mean the deep of invasion, myometrium? No.
This is already a myometrial tumor. That's already
Areas of necrosis.
yeah, areas of necrosis. If you have an area of hemorrhage, area of necrosis, you need to focus on that, and also the fleshy or myxoid areas. Fleshy myxoid areas. If you have like an area which look very myxoid, you can see that there is some kind of mucinous or some kind of mucin there, or myxoid areas submit from these areas so that you look for atypia, mitosis, tumor type necrosis, and this kind of stuff. And that's when you will upgrade the cancer and say this is leiomyosarcoma. This is highly likely to be a leiomyosarcoma or something. Our next entity is the endometrial stromal tumors. You will get a question every now and then in the Q banks for the boards about these endometrial stromal nodule and endometrial stromal tumors. You need to know that this is not coming from the smooth muscles, it's coming from the stroma, the endometrial stroma. That's called endometrial stromal tumor. It's coming from the stromal cells, the connective tissue cells in between the glands, the stroma. You need to be able to differentiate between what we call endometrial stromal nodule, low-grade endometrial stromal sarcoma, and high-grade endometrial stromal sarcoma. Let's start by immunohistochemistry first. Make sure you remember that there are 3 stains that you need to order if you are suspecting a stromal tumor: CD10, ERPR, and cyclin D1. CD10, ERPR, and cyclin D1. Okay, if you see that there is a well-circumscribed stromal lesion with some stromal cells there, and you look under the microscope, that's low-grade. It's the cells are very bland. They don't look very atypical. They don't look very ugly. And then on immunohistochemistry, you see that this is positive for ERPR CD10. So they have like a positivity of immunos which look like the normal endometrial stroma. So that's endometrial stromal nodule or low-grade endometrial stromal sarcoma. How to differentiate between these, I will tell you right now. So see, the endometrial stromal nodule is only a single one. You see only a single lesion, very well circumscribed, with no lymphovascular invasion. It's not sending any infiltrative edges in the myometrium. And it's just resembling it under the microscope. It resembles the proliferative endometrium, like what you see in proliferative endometrium, resembling proliferative endometrial stroma. That's benign. That's endometrial stromal nodule. It's CD10, ERPR positive, not cyclin D1 positive, cyclin D1 negative, okay? What about the low-grade endometrial stromal sarcoma? You will see multiple lesions in the myometrium. And the lesion is like, it's as if it's sending some tongues. That's why he's putting this picture. It's sending some tongue-like projections, or they look like as if they show them tongue-like invasion in the myometrium. That's a sarcoma, but it's very low grade, very good prognosis. No worry about it. So see, it's a malignant tumor. However, it's a low grade malignancy composed of cells resembling also proliferative endometrial stroma, but you have some kind of infiltrative / permeative growth into the myometrium, and you might see some LVI or lymphovascular invasion. They send some tongue-like growth or tongue-like projections, and they always get you the picture with these tongue-like projections. Still, this is CD10, ERPR positive, cyclin D1 negative. The molecular mutation is very important. The Jazz F1 SUZ12, Jazz SUZ. So Jazz F1, I always remember the Jazz F1 for some reason, because remember me of the jazz. The jazz is a kind of a musical instrument, or whatever. So the Jazz F1, I always remember it. So the Jazz F1 SUZ12, this is very important fusion and very important molecular association with the benignish stromal lesions, which is the endometrial stromal nodule or the low-grade endometrial stromal sarcoma. However, if you go up to high-grade endometrial stromal sarcoma, that's the ugly-looking sarcoma cells, you see this. You see how hypercellular the lesion is and how pleomorphic the nuclei are. See the difference between this nucleus and this nucleus and this nucleus and that nucleus. Oh, that's very pleomorphic, very ugly looking, high-grade sarcoma, CD10 ERPR negative and cyclin D1 positive. See? Cyclin D1 positive, ERPR negative. CD10 is some kind of variable. However, it's usually negative in the most common one, which is showing this not M, and BCOR alteration. BCOR is always a molecular association with high-grade sarcoma. There is even some soft tissue sarcoma, which are BCOR mutated sarcomas, which is there in bone and soft tissue. We will encounter these. They are always also high-grade, roundish, and very pleomorphic looking sarcoma cells. It's the BCOR type. So when you see this BCOR and this not M2A or YWHAE mutations, you always see that the CD10 is usually negative, and the okay, Abdurrahman. Okay, Alia. All right. So I saw that it's Abdurrahman because it's a letter A, but it's fine. So okay, Alia. See you tomorrow. Alia said that she has to leave. All right. So that's the high grade. So high grade endometrial stromal sarcoma. You see these high grade cells, and it's CD10 and ERPR are usually negative, and cyclin D1 is usually positive. So see high grade rounded cells or spindle cells. Sometimes it's usually rounded cells. Sometimes you see some kind of permeative destructive growth, high mitotic activity, high necrosis, LVI, of course. The most common two molecular alteration is the NUT, UYWHAE. That's what I called UHAE. UHAE, not M, fusion, and the BCOR alteration or the BCOR mutation. You don't need to memorize this table, just memorize the scheme for IHC. It's saying CD10 ERPR are usually positive in the low grade or benign tumors, and that cyclin D1 is always positive in high grade endometrial stromal tumors. That's it. Some kind of other mesenchymal. These other mesenchymal, that's the ones I told you that it's not so important. What's there? Leiomyoma, Leiomyosarcoma, endometrial stromal tumor, and high-grade and low-grade endometrial stromal sarcoma. These are the most important ones. The other mesenchymal, well, like undifferentiated uterine sarcoma, well, he's saying that this is a diagnosis of exclusion. You don't have any specific line of differentiation. It's just an ugly-looking sarcoma with a poor prognosis. Well, it would never come in the boards. Also, uterine tumor resembling ovarian sex cord tumor. I never saw that. But you might need to know the rhabdomyosarc. It come anywhere though, but it has this characteristic looking. What are these cells? Anybody can tell me? What are these cells?
Rhabdoid.
Yeah, the rhabdoid cells with this eccentric nucleus, prominent nucleolus, and the glassy pink cytoplasm with some kind of cytoplasmic striations. And it's always positive for the rhabdoimmunos, which are the myogenin and MyoD1. That's for the skeletal muscle. So it's malignant tumor showing skeletal muscle differentiation like rhabdomyosarcoma anywhere. It might also come in the uterus. Picoma, as I told you, but we will never get a picoma of the uterus. You get a picoma of the soft tissue, but you will not get a picoma in the uterus. Even inflammatory myofibroblastic tumor, I understand how important this entity is, but it's always there as an abdominal soft tissue mass, rather than you get it as a uterine mass. However, inflammatory myofibroblastic tumor, you need to remember that it's myofibroblastic. So this means that you have the spindle myofibroblasts, and these kind of fusiform nuclei, the myofibroblastic differentiation, and it's tumor. Well, yeah, there is a mass. And inflammatory, this means that you will see some kind of lymphoplasmacytic infiltrate inside the tumor. This is not the best picture. We have better pictures in the soft tissue notes that I will show you. But you will have some lymphocytes and plasma cells infiltrating. That's why we call it inflammatory. Always the question is ALK. Always the question for inflammatory myofibroblastic tumor is the ALK mutation. You have to do ALK staining and see whether this is ALK positive or ALK negative. More than 95% of the IMTs are ALK positive, and showing the ALK rearrangement by molecular staining. And we will cover this, of course, in the soft tissue tumor. Entrac rearranged spindle cell neoplasm, I never saw it anywhere in the questions. This one, it comes, but it comes in the testis, honestly, not in the uterus as well. However, you might get that, so let me go over it. That's adenomatoid tumor. It's a board favorite, but they always come in the boards or even in the RISE exam as a peritesticular mass. You know that, right? It comes in the mass around the testis. It's not in the testis, but in the tissue around the testis. It's a peritesticular mass. And when they give you the picture of the tumor, you see these gland-like, slit-like spaces. See these spaces? Pseudoglands. They are not acini. They are not glands. You need to know this. These are pseudoglands. They look like tubules. They look like glands. So see variably sized tubules of pseudoglands. However, this characteristic and pathognomonic finding that they always present in all the picture is these threads. The bridging threads. See, another one is here. The bridging threads in these pseudolumens and these pseudotubules. They always ask, what are the positive immunostains? D240 calretinin. Well, okay. D240 calretinin WT1. This reminds you of the immunostains for what? If I say D240.
Mesothelioma.
Yes, good job, Mariam. Good job, Abdurrahman. Mesothelioma and mesothelial lesion. D240, calretinin, WT1. And there is another important marker for mesothelioma, which is, it came in the last prize. Yes?
Yeah, EP4, forgot.
BAP1.
That one.
BAP1. It's BAP1. BAP1, it came in the last RISE exam. I don't know if you remember, but it came at a question in the last RISE. This one, it shows intact BAP1. And that's what differentiates it from mesothelioma. Mesothelioma usually have BAP1 loss, but here D240, WT1, calretinin are positive, and that's why they believe that this benign tumor, which is the adenomatoid tumor, is actually of mesothelial origin, because we have positive mesothelial markers, including D240, WT1, and calretinin. However, we still have intact BAP. There is no BAP1 loss. Please memorize and remember the thread-like bridging strands. These are very important histopathological feature for the boards in this tumor. Peritesticular mass. It never comes in the uterus, honestly. Other than this, we already covered these entities. I'm sure you remember the APA and the adenomyoma, which have the endometrial glands and some kind of endometrial stroma and some smooth muscles with a polypoid lesion. You remember this adenomyoma? Carcinosarcoma. Abdurrahman, I think we covered these, right? Carcinosarcoma, and we said that it has this carcinoma part and sarcoma part, and you need to report the percentage of both, right?
Yeah.
Yeah, we covered this already in the endometrial lesions. I don't know why he's
I think so.
but it's okay. Like, you can go over it as a kind of revision. It's a biphasic tumor, which has like sarcoma component and carcinoma component. And the carcinoma component sometimes shows some squamoid or squamous metaplasia / squamous carcinoma component. However, you see epithelial component, sarcoma component. And you need to report the percentage of both. And it shows also TP53 mutation, very aggressive, and sometimes they call it triple MT, right? MMMT. It's always in the old or young aged females, and the mass is always large or small. So 2 questions here. Is it in the young or old? Yes, Mohammed?
Mass is large, and I'll
Mass?
give my colleagues to answer the A.
Okay, so mass is large. Mass is large to the point that it might protrude out from the cervix.
Yes.
Vagina.
Yes.
Yeah, you remember this.
Mhm.
And is it young or old age? Is it a tumor of the young or old age? Anybody can tell me? Young, old?
Average 50. Not
Average? Yeah, that's old. It's in old age females. It happened in old aged females, and it has a large mass which is projecting outside the lumen of the cervix or the vagina, projecting out, and it kind of have a distinct morphology when you bivalve the uterus and open and you see this huge mass. That's very bad. That's highly likely to be triple MT. That's adenosarcoma. You remember this? We said that this looked like phylloides, the leaf-like. This adenosarcoma is like the phylloides. It's a kind of also mixed epithelial and mesenchymal tumor. You have mesenchymal component and epithelial component, and it shows this leaf-like polypoid projections, which are entirely filled or stuffed with stroma. These like leaf-like projections, you feel like it's totally stuffed with stroma, like a sandwich. It's filled with stroma. So stromal leaf-like polypoid projections, broad, which look like the phylloides tumor, and it's actually positive for stromal stains, CD10, ERPR. It's a low-grade malignancy, although we call it adenosarcoma. Sometimes you feel like, oh, this is sarcoma, that's very aggressive. Nope, that's a low-grade sarcoma. It's not very concerning. However, it shows this phylloides-like leaves, which look like phylloides tumor of the breasts. Okay? Any questions? Anybody have any questions? All right, that's the comeback. So we try to make a comeback. So I will see you guys tomorrow. Tomorrow we will start the non-neoplastic thyroid. Hopefully, my plan is, hopefully, we will have Tuesday, Wednesday, and Friday. That's the plan. That's the provisional plan. Tuesday, Wednesday, and Friday. So 3 lectures. I will cover non-neoplastic thyroid, and then neoplastic thyroid, and then salivary gland pathology. I'm planning to do the salivary glands in 1 lecture, and this is so tough. So we might need that day to, maybe we can meet earlier, like we meet at, anybody has a problem meeting at 8? 8:30? What do you think?
Which day?
Well, it should be the Friday.
Well, it should be fine.
Yeah, well, if you will be late, like you'll come at 8:30, give us a heads up on the Telegram, okay?
Okay.
All right, but so that because I want to finish the salivary gland, so that I feel like I'm almost done with the head and neck, you know? So this week we'll be like almost done with the head and neck. I have only the other selected head and neck topic, and this is 1 PowerPoint presentation, and I will put the entities, which is high yield for the boards and for the practice, and that's it. We won't go in depth in like the mandibular lesion, because mandibular lesion by itself gives you a pain. But in the boards, it's very like there are some specific entities which are boardable: adamantinoma, odontogenic cyst, these kind of things. All right. All right, perfect. Thank you very much, everyone, and
Thank you, sir.
see you guys tomorrow in the non-neoplastic thyroid.
Thank you, and hope you feel better soon. Thank you.
Thank you.